Good afternoon to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Tripura Sundari. Ma'am is MBBS, MD, DGO, FIMS, consultant and HOD of Ops and Gynecology at Kim's Hospital. With the help of ma'am and her wonderful insight, we will be taking a close look on today's topic, which is methods of MTP, medical termination of pregnancy. Now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her. Over to you, ma'am.
Good afternoon, everybody. I thank you all for joining me today in the afternoon session and the hot sun. And we are talking about the very, harder for many of the obstetricians. At the same time, it is a terror for many people because so many times we end up in complications or there may be some legal problem. So we should know what is to be done and when it should be done. This is welcome to a city fair where I'm hospital for obstetric and for children also. To tell you about MTP Act in India, see some countries are going forward, some countries are going backward. I was surprised recently, a very advanced country like America has gone back on MTPs and they have banned MTPs, which is I think very women empowerment. The medical termination of pregnancy started long back. 21, it came to force in September. It extended the upper limit of gestational age for abortion from 2024, which is welcome.
Sorry to interrupt, ma'am. Your video is stuck because of which we can't hear you, and your video is also not moving.
Access to comprehensive care. That is the MTP Act of India 21, which is contracted in actually 23. The new 22 Act says we can do MTP up to 20 weeks and for 24 weeks, the opinion of two medical practitioners is required. This is very important because so many times MTP are done with problematic it becomes too. Beyond 24 weeks also. Board consent, it is required, especially it is in cases where it cannot be corrected. So the patient may ask for an MTP, a medical board can go ahead. Who can perform abortions? Abortions can performed by English medical practitioners, but only in the approved facilities only. Of course, there are MTPs done in very small areas. As far as you are not caught, you are okay. But if you are caught, you'll be put with non-bailable warrant. Some rules of MTP. Written consent from the pregnant woman is very necessary. If she is a minor or a mentally ill, the consent of guardian is required. Abortion should be carried out only in government or recognized medical centers. Indication should be mentioned, no name to be entered, and case sheets to be preserved, and monthly reports be sent to the DMHO. And they can come and ask you for a case sheet anytime. You should be ready to present it. And as long as you do an MTP within the legal purview, there is no for the doctor. Coming to methods of MTP, first trimester, that is up to from confirmation of pregnancy 12 weeks, you can do either medical surgical. Second trimester from 12 weeks to 24 weeks, you can do either medical or surgical. And nowadays, everything medical is preferred. First trimester, you can use, now we were so many drugs we used previously, but now latest you got mifepristone and misoprostol. Mifepristone 200 milligrams tablets are available. You give it, wait for 48 hours, and you give misoprostol 600 to 800 micrograms per vaginal or sublingual. It may be repeated fourth hourly if needed. Patient usually 90% abort on their own. You can check scan after a week and see for any RPOC. If it is there, even then also you repeat misoprostol, 90% will the probably RPOs comes out. Very rarely you may have to do a check retouch. But if you are that the check retouch may be needed, she may bleed, and she must always give you a phone number. It can be done as a NOPI procedure, but you must give your patient your phone number so she can contact you at any time. Or if there is a bleeding, which occurs in around 10% of patients, she must be had so that negative. You must always warn her, and an antidote should be given so that she doesn't get activated. So before doing that, you should always have a pre-empty. So it's always important for you to get a scan. Again, you have to bring metal then do it as synchronizing. But with the invent of misoprostol, you can give misoprostol, wait for a few hours, then you can do suction evacuation because that makes the cervix soft and dilatable so that you can just use the carbon silicon cannulas and do the evacuation with vacuum aspiration that causes minimal damage. This is usually done when it is more than 10 weeks. Between 10 and 12 weeks, you can usually use that. Medical abortion is safe up to 9, up to 7, can be extended to 9 weeks. Beyond 9 is always better you do a surgical because a bleeding, cervical tear, and in long term it can cause cervical incompetence. And is the in future infertility may be there because of the damage to the endometrium. Coming to second trimester abortion, again it can be medical. Using mifepristone prime followed by misoprostol is a safe practice. Only misoprostol may take a longer time. Syntocinon was used very many people, but not much of use as a single agent. You can prime the cervix with Ceriprime, followed by again Syntocinon, especially when it is around 18 weeks or 20 weeks. You can use as catheter as a bougie, allow the cervix, or rare cases you can use can do section evacuation, having 3 previous sections. Hysterectomy, but very rarely some patients insist as a part also. When medical abortion fails, you may have to go for a hysterectomy.
Uh, Ma'am, sorry to interrupt again. Your video is stuck, ma'am, because of some network issue from your end. Yes, ma'am.
Hello?
Yes, yes, ma'am. You're audible now.
Sorry.
No, no, ma'am. That's fine. You can continue again.
powerful content make the scar give way. And there are many cases where there are rupture occurring. So we have to avoid prostaglandins as far as possible. Always take consent for hysterectomy. You should try to do a medical abortion. Always take consent for hysterectomy, because again she should not fight with you. They'll say that you did, you'll do medical abortion. We give around 200 milligrams, wait for a day or two. Once the fetal disappears, you can put a intracervical catheter, wait for again 1 or 2 days, and usually cervix dilates under antibiotic coverage. You wait, and mifepristone and syntocinon may be started once the dilatation is there. And sometimes, if they already dilatation 3 to 4 centimeters, you can give even misoprostol. So, mifepristone will make
Uh, Sorry, viewers, for the disturbance. Actually, ma'am is facing some network issue. She will be joining soon. Hello, ma'am. Am I audible to you? Ma'am will be joining soon. Hello, ma'am. Am I audible to you now?
yeah. Arasi,
Yes, ma'am. You're visible as well.
slide better. Yeah. I- This is slide better. This is slide disturbance. So once the process is expired, you can check it as ultrasound guidance. This is a safe method. Only thing is, you should have little patience and counsel the patient and wait, so that it is not a question of money, but the patient can have for the see. For example, recently we had a patient who was a fourth gravida, had three abortions, three sections, but only one live child. She never wanted a sterilization. So such patients, if you are patient and abort like this, she can have chance to have one more child. So as in special situation, you should be able to do with medical abortion using either on and will help in the patient abort it. And there are some situations where the patient is having heart disease, or the patient is having twins. In such patients also, if you give unnecessary syntocinon, she may have a rupture or she may have amniotic vein embolism. So you must be careful in doing such patients, especially in MTP. And always I tell you, you should be careful and take consent for hysterectomy, because you should not land up again in a legal battle. We do everything for the patients safety, but sometimes we should all think about our own safety. What are the complications of MTP? First and foremost is hemorrhage. Hemorrhage is one which occurs even in the first trimester or second trimester. Nowadays, we are seeing patients taking tablets on their own. They are now in India, anything you can get across the counter. So patients, once the test is positive, they're taking on their own, coming with irregular bleeding, 15 days, 20 days. Sometimes they're coming to our OP and collapse with the bleeding, because one thing is you do not know whether it is intrauterine or ectopic, or if it intrauterine also, all abort cases will not abort, and they will not know the number of this. Especially this happens when the patient is having a illegal pregnancy, or the patient wants to keep the pregnancy secret, so they don't approach doctor in time, and you may find the patient in hemorrhagic shock. And next, when you do a medical surgical abortion, perforation is again a more common thing. Again, now when in case of previous section, when they take tablets, especially maybe misoprostol, this scar may give way and you may end up in a scar rupture. Sepsis is not there, shock can occur. Sepsis and shock are again a common thing. And think about the patient having lost the child, the patient may go into psychological distress, and pregnancy is there around 2020 week, you find herself a baby is abnormal, or the certain IUD is there, and you terminate the pregnancy, we can think about the amount of psychological distress she'll be there. Family is disturbed, so you should be very careful. Coming next to long-term implications, that is fertility. If the patient is having repeated abortions, this may end up when you do curate the endometrium is all disturbed. Fertility, or the sepsis is there, the tubes may be blocked, she may go into again the other recognized center is there, because in spite of taking consent and doing things, you may end up in a legal problem. Recently, we had one patient who was brought to us by a known person saying that she's a daughter. So it was second trimester abortion. We terminated because husband, so-called husband, also signed. And after termination, everybody disappeared, and the patient came back to us with high fever. And again, her mother, her real mother, came and gave a complaint that we had done a thing without informing her. As patients, when somebody comes and tells us, we can't ask for Aadhaar card for every patient. Of course, it shows that we should ask for Aadhaar cards, but they have created such a situation that we had almost to go to a legal battle and say that we were innocent. So taking a recent complaint and again doing the work for them and again getting a this thing complaints from them is very problematic thing. So you must be very careful when doing MTPs, especially in second trimester abortions. And nowadays, patients are going around places, in spite of all the PCP and DT Act, they are doing scans somewhere or other, they're getting the sex known, and they come to us, they don't tell us that they're getting this MTP done for the scan. They say some problem is there, the husband left or they have gone divorced. So she got every right as per the rules to get an MTP done. So we innocently do the MTP, and usually the medical, the DMNH people are following up the cases. So when the patient has a scan, every scan center is followed up. When the patient has a scan around 18-20 weeks, they follow the patient. If the patient doesn't deliver, they come back. Where did she have the MTP done? And again, you are caught there. So please don't fall into the patient's history and the class and get yourself into problems. So please try to find out what is the cause for this thing. Unknown people, please be careful. Don't get yourself entangled in legal battles. Thank you. I think I have just covered the thing, and we have to talk about it in detail. It takes longer time. So I thank you all for the patient listening, and any doubts you have, you can ask. Thank you.
Yes, ma'am. Thank you for your wonderful presentation, ma'am. We do have some question from our audience if you'd like to take that up.
Yes.
So, ma'am, the first question is, what are the common medical methods for MTP and how do they differ?
I think I've covered it in my talk. The first trimester MTP, commonest, safest thing what we are doing now is with mifepristone and misoprostol. Mifepristone acts on the this thing, It's not from here. The acts on the progesterone receptors. Once it blocks the receptors, there is no supply to the this thing fetus stalker. Once this happens, you can use misoprostol. This misoprostol usually takes 600 to 800 milligrams per vaginal or sublingual, and is usually within 12 to 24 hours. The patient aborts, and once it then you can do a check and see after 24 hours after the patient is given medical abortion by the OP procedure. You can ask her to come back for a scan after 1 week, and if there is no RPOC, she is safe. And this is usually 90% successful, and patient can be safe and less amount of cost and less amount of bleeding. But every case is not same. I tell my patients my hand, all 5 fingers of my hand are not same. So any patient, I would say 99 patients are normal. One patient can have problem. We don't know which is that one patient. So you have to consult the patient. You have to inform the patient about the amount of bleeding, incompleteness, read for evacuation in case it does. Sometimes again one patient 2 times scores, it never about the fetal heart was still there. So that such stubborn babies are there, we should say sorry and do go for a surgical evacuation. So this should be informed to the patient in the beginning itself. Take a recent content consent, even if it is a OP procedure, please take the consent, inform them that there may be a need evacuation, this may not be successful, there may be bleeding, that report us. Because sometimes patients do come to us that they have taken tablets somewhere else 15 days back, now she didn't get the bleeding, now we see from 6 weeks she has gone into 8 weeks now. So these problems do occur. So you have to inform, take a written consent and do it, then you are safe. Another thing what the BMWH people ask is not to write down the patient's name in any of the case in case she is admitted, because you are not supposed to reveal the patient's identity. Only put the name and send it, because these are the small things you have to follow. This is the medical abortion procedure which we are using now. And if surgical, of course, is suction evacuation between 10 to 12 weeks. There also, you give misoprostol, wait for a few hours, the cervix dilates on its own, and you can do a checker-attach. Then the patients can be sent home the same day. We follow this even at 6 to 8 weeks. In case patient is having a VOH, we want to send the fetus for microarray, then we just give medical abortion, she aborts on her own, and we won't get the products for conception will be sent to this thing. So when we want the patient's fetus to be sent for microarray, then we have to do a surgical abortion. Then we send the collect the page, this thing, send it for cytology, genetic analysis. We know whether there's any fetal genetic cross for the abortion. So this is usually done when there is a consanguineous marriage or patient is having a RPO, recurrent pregnancy loss. In such cases, we do medical abortion. We may give misoprostol, but we do suction evacuation, send the products in the saline for microarray so that we get the reason for the MTP.
Thank you, ma'am. There is one last question. What measures can be taken to continuous improvement the quality of MTP service?
Pardon me.
The question is, what measures can be taken to continuously improve the quality of MTP service?
First thing is your setter should be registered and take the all aseptic precautions. Take consent, and you know that of course it should be done by a qualified person. Then these 4 things are done, and you keep the blood grouping, and also if it is RS negative, inform them, give the anti-D. Then the safety is the patient should be safe. She must be able to conceive in future, and your skin also should be saved. So for these things, please do MTP only at the recognized centers, and even if you take medical abortion in the OP, take a consent and inform them. Take in a paper, in a book, you can take a written consent that I've been informed that 95% will abort spontaneously, or some patients I may have to come back for termination, or if they by a surgical evacuation or the income abortion, I may need a DNC. I've been informed. If you this much, if you write and keep, then you are safe. Nothing happens. And do it a medical abortion, or if you do, of course, they are at home. So you should give your phone number so that they can contact you if there is a problem. Because tomorrow, what happens? She bleeds in the night. You are not available. She goes nearby doctor. We know our doctors. We try to put blame on the next doctor. There are a few doctors like that. Then unnecessarily hue and cry. Instead, you give your own phone number. In case any problem, please contact me. So that you can guide them wherever you want. And what is their maximum that's going to happen? You'll have a bleeding, you may have to go and do a check retouch. So you are safe, patient is safe. So try to do an abortion in first trimester as far as possible medically, and take consent, do a group and do a scan. Try to know whether it is intrauterine pregnancy. If it is a scarred pregnancy, like previous myomectomy is done or previous section is done, try to avoid prostaglandins. As I told you, you can give mifepristone first, wait for 2 or 3. If it is around even 20, 22 week also, you can sometimes give mifepristone 2 tablets or for 24 hours dipping. Wait for the fetal heart disappear, then try to do a bougie. And about once it is done, of course, 3-4 centimeters, you can say a Synto drip or a misoprostol can be given. But always, I'm little bit scared for using misoprostol because we have seen cases where it has ruptured badly, so that we had to do a hysterectomy for the patient who had come from other centers. So I advise not to use misoprostol for a scarred uterus. It may take a day or two more. You put a catheter, wait. Once it is started acting, you can put a syntosnon or misoprostol so that you are safe, patient is safe. And always try to keep the thing in confidence. Say patient is already distressed. She may be getting the MTP done for various reasons. So you must, as a doctor, you are more like a mother to her. So try to be considerate with them, help them so that they can come out of the social problem. There are many causes where MTP is done for social reasons. So you must be able to help them.
Thank you so much, ma'am, for answering all our questions. So, ma'am, before concluding today's session, any last remark from you?
I thank all my doctors who joined me today in this hot sun for this discussion. Any doubts you have, you can always contact me. And MTP is a tricky thing. As somebody said, it is the bread and butter of many of the obstetricians. At the same time, be careful. It is a double-edged weapon. Once the patient aborts, she is happy. She doesn't abort, or the as I told you, the legal battle sometimes will lead you into, especially this termination of pregnancy in second trimester, where sex determination you may not have done, but somebody might have done, and they come and they'll not tell you. There's some reason. So ultimately, may be entangled in that. So be careful, and you'll both you and your patient should be happy. Thank you.
Thank you so much, ma'am.